Good morning, everyone. Welcome to our invited lecture series of the Global Neuroscience Institute Grand Rounds. It's my absolute pleasure and honor to introduce our speaker this morning, Dr. Bernard Bendock. Dr. Bernard Bendock is a dual-trained endovascular cerebrovascular neurosurgeon. He did his training at Northwestern University under the tutelage of Dr. Hunt Bacher, who's one of the giants in vascular and skull-based neurosurgery, and then went on to become a dual-trained endovascular neurosurgeon and did his fellowship at the world-renowned at the time institute, and really only place to truly train at University of Buffalo, and stayed on as faculty at Northwestern, and then was stolen from there to Mayo Clinic, where he is the William and Charles Mayo Chair and Professor of Neurologic Surgery. He is Professor of Neurologic Surgery, Otolaryngology, and Interventional Radiology, and actually radiology as a whole. My introduction for Bernard's accomplishments are way, it would take the entire session here. He is a true thought leader, and that term gets thrown around quite a bit. Dr. Bendock and myself and several others were one of the first handful of people to start doing endovascular as neurosurgeons. So he was really one of the kind of next generation founders, and has just absolutely been a beacon for everyone that is either training now or practicing now. So with that, what he's going to talk about this morning is advances and innovations in arteriovenous malformation treatments, of which he's an expert. His bibliography, he has hundreds of peer-reviewed publications, book chapters, lectures globally around the world, is a leader in simulation. Most of the simulation today was born out of some of the early concepts that Bernard worked on very early. So with that, it's a pleasure to introduce Dr. Bernard Bendock.
Errol, thank you for that very, very kind introduction. I should have had my mother log in. Thank you so much. Very kind of you. But I'll have to say that all the nice things that you said, of course, are very nice, and I appreciate them. But what I'm most proud of, to be honest, is the fact that I could be considered a friend of Errol Vez and a mentor, colleague, and friend to Rudy Rami, and I'll mention also some of your other faculty shortly here. So that to me is when it all said and done, that's the accomplishment that I think has most meaning in life. So brain AVMs, and I changed the title just a little bit, just to mix it up a little bit, from mythology to team-based victories for our patients. And I don't have any financial disclosures. I have many biases, and I am sorry if I'll offend any of you in the audience today. In fact, it is said that academically, if you don't offend, you're not expressing an opinion. So opinions will be expressed. They're meant to be respectful and open to debate on all fronts. So we welcome debate. In fact, I think it's a good thing to debate. It's good to offend each other a little bit. And I don't mean offense in the colloquial sense, but more in the sense that you're triggering a counter opinion in someone else, and that's okay. That's a good thing. Again, want to thank Errol Vez. Really admire what he's done in his career, but beyond his and with the GNI, really amazing work, enviable work, spectacular work with all of you, and the team has been able to assemble from neurology and APPs and nursing and neurosurgery. But what I admire about Errol is his tenacity, his honesty, and his ability to push beyond accepted norms and to get to the truth of things. Sometimes we confuse dogma with truth. What happens to human beings is we form hypotheses to get to the truth. Sometimes those hypotheses become religion and dogma, and that stalls science, it stalls progress, and Errol Vez is the antidote to that. Because he questions the status quo, doesn't accept the status quo. So that's what you need to move a field forward. You have to get to the edges of the field because you have to question where you are now. If you accept where you are now, you'll pretty much be stuck. Rudy Rami, I've had the pleasure of playing a minor role in this young man's career. He was a research fellow with us at Northwestern, then a resident. I unfortunately had to leave him after he matched at Northwestern, shortly into his residency, to come to Mayo Clinic, but we couldn't spend too much time apart, so he joined me as a fellow, and we absolutely, truly loved having him as a fellow. And anytime I see a patient with whom he had a note left, I know it's going to be a good note and a good assessment, and I look forward to, so I get reminded about Rudy for many reasons, but not the least of which is just the clinical impact he had at Mayo Clinic. And I look forward to watching his career grow. And I couldn't have had him at a better place in the GNI under the tutelage of all of you and Dr. Vez. I felt safe, because you always want your trainees. They're like your children or your cousins or your relatives. You want them to be in good hands. And I knew that he'd be in good hands with the GNI team and Errol Vez. I have a deep admiration. I've gotten to know your neurosurgeons over the years. Dr. Hakma, I've gotten to know, incredible gentleman. I haven't gotten to know the other neurosurgeons as well. I look forward to meeting Dr. Sarkar. I have met Dr. Sarkar, but look forward to getting to know him better. Dr. Strenger and Dr. Loven. Dr. Binning, I've had the pleasure to get to know, just a phenomenal neurosurgeon. Really admire her, and excited to watch her career, and was honored to write a minor chapter in a book she's editing. And Dr. Liebman, of course, a giant in the field, and really always a pleasure to see Dr. Liebman. And what I've been very impressed with, and neurosurgery is renowned for, it's like the band that can, neurosurgery is like the band that can never stay together. And you guys have formed a band that has stayed together, and that is quite impressive. That speaks to the culture and the bonds that you've been able to gather around, form around common values. Just an acknowledgement of my team. Anything I say today is not just me, but this is an older, pre-COVID. Our department now is 3 times the size it looks now, and very honored to represent them today. And our AVM team is my neurovascular colleagues, Dr. Krishna, Dr. Turkwani, Dr. Chong, and of course, we can't do anything without stroke neurologists at Mayo, neuroradiology, who keep us honest and on target, and radiation oncologists who we work with very closely to look at alternatives for AVMs, radiosurgery, proton beam, et cetera. And of course, we formed this very unique brain mapping team. They come to us, they have a clinic, they come to us to the OR, and they're involved with post-op assessments and any psychology needs. Dr. Baxter is a psychologist who helps us with functional MRI. Dr. Dries and Musica are neurology electrophysiologists who help us with awake mapping, white matter mapping, et cetera, et cetera. And of course, Vanessa Vanderhei is a pillar of our program as our stroke center expert. We recently received stroke center certification, and Vanessa works tirelessly for our team. So, and we formed a residency a couple of years ago. I'm very proud of them. It's a budding group doing great work. And of course, I should acknowledge Dr. Bethini, who is a protege of the GNI. He stood out as the best applicant of the many incredible applicants last year. He was a GNI protege, and turning out to be a phenomenal. He now has 3 times the case log of the average intern in North America for neurosurgery. So my goals today are to dispute some commonly held beliefs. Again, I'm going to, inspired by Errol Vez, I'm going to challenge the status quo a little bit. It's always good to do that, to poke the status quo. We have to do that from time to time. I'm going to share some of my very biased thoughts on how I think about treatment options. They're just my thoughts. They may be wrong, they may be right. You may differ, and that's okay. Share some creative solutions and recent innovations, and hopefully look a little bit to the future. So to our audience members, you know, most of you are familiar with AVMs, but it's always good to review the basics a little bit. And AVMs involve an abnormal connection with arterial and the venous system with an intervening capillary-like nidus. It's a tough, I sometimes refer to it as a spaghetti bowl of abnormal vessels that are sometimes fragile and can rupture. Cartoons are easy. AVMs are 3-dimensional, sometimes monsters, but there are components that are important to think about: feeding arteries, anitis, associated aneurysms. And sometimes the associated aneurysms are as dangerous or more dangerous to the patient than the actual AVM. And there's a side I like to think about. This has received more attention in recent years, is the venous side. Most people, when they look at an AVM, not the GNI team, but most people kind of forget about the veins. And I think sometimes the most interesting part of an AVM is on the venous side. Over the years, venous stenosis can develop, and that may be the trigger for rupture, or maybe part of the pathophysiology, what I call venopathy. And I encourage the students in the audience to pay attention, not just to what catches your eye is the arterial side and the nidus, but pay attention, watch what's happening in the veins. Not always easy to decipher because it's a spaghetti bowl that you have to unravel, and not easy sometimes to study. The estimated incidence is lower than aneurysms, 1 in 700, 11% of all vascular malformations. But what's really important about AVMs is it's the most important cause of hemorrhagic stroke in young individuals. If Errol or I get a call about a 30-year-old woman in the ER with a lobar hemorrhage, it's an AVM until proven otherwise. It may be other things, but AVM is high on the differential. So while it's not the most common cause of brain hemorrhage, it's a minor player in the overall brain hemorrhage world. It's important because it tends to hit people at a young age when they're a young professional, a young mother, a young father, just starting their career. So it has a huge impact. It can have a huge impact on life and society. So this is something important to think about, is what does an AVM do when it ruptures? And to my surprise, this has been minimized in recent literature. There's been some suggestion that, well, AVM hemorrhage is not so bad. Well, you haven't lived with me or Errol in the ICUs. Errol and I spent our 20s and early 30s living in ICUs. And I can tell you AVM hemorrhages are not always benign. So when an AVM hemorrhages, 13% of patients are moderately disabled, 3% are severely disabled. There's about a 50% severe neurological deficit after bleeding, and a 10% mortality after hemorrhage. That 10% may be underestimated because not everybody makes it to the hospital. Clinical presentation, for symptomatic presentation, hemorrhage is the most common, followed by seizure, mass effect symptoms, headache, brewy steel. Incidental discovery is more and more common with all the MRIs we're all getting. And an area that has been understudied that I find fascinating is cognitive impact. We've seen patients with big frontal lobe AVMs that have severe medically refractory depression. We've seen AVMs in children and young adults in the basal ganglia where they have learning disorders. We saw this one kid who had a huge learning disorder with a big basal ganglia AVM, but he could play any piece of music just from hearing it without any formal training. So this unusual rewiring of the brain can occur with AVMs, and we don't know much about it. I think we're just starting to understand that. In kids, you see hydrocephalus with microcephaly, congestive heart failure, and prominence of forehead veins. Posterior fossa AVMs, I have a special interest in this. It's 20% of all AVMs, interestingly. And what's interesting is that most of them have bleed on presentation. Studies suggest higher risk of bleeding, greater morbidity and mortality, higher association with aneurysms. So these are a more aggressive form of AVMs. Most Vermean AVMs I've met with people in coma in the ER, versus a frontal lobe AVM, you meet them in other ways. So there is a heterogeneity of presentations. These are more dangerous than their supratentorial cousins. So an AVM is not just a static culture. We're always biased by what we see. When you look for the truth, you're biased by what your eyes see and what you hear. So you see an AVM, it's a two-dimensional structure on MRI, and you get told by radiology, rightfully so, that the AVM is unchanged. Well, AVMs are not static. There's inflammation, hemodynamic stress, ischemia, angiogenesis. Why does an AVM that you're born with suddenly rupture when you're 33? Something must have happened. It didn't happen overnight. It's an evolving biological story. I'm not going to go too much into grading scales, but just to mention, this is a surgical grading scale. Just for those of you in the audience who haven't dealt much with AVMs, smaller AVMs in quote unquote non-eloquent areas, and AVMs that don't have deep venous drainage tend to be very low risk for surgery. So a grade 1 and 2 AVM, let's say a 1 to 2 centimeter AVM that is in the frontal lobe, superficial, with cortical venous drainage tends to have a very low risk of surgery versus an AVM that is large, deep, and eloquent area can have a prohibitive risk for surgery. So grade 1 and 2, and you can add the score there on the right. A grade 1 or 2 AVM is very low risk for surgery. 3 is intermediate and is a mixed bag. Grade 4 and 5, you typically are much wiser leaving alone unless they're symptomatic or unless you want to just treat an associated aneurysm for the most part. Some of them become symptomatic and need treatment. So you can't really talk about AVMs today without talking about the elephant in the room. That's the Aruba study that was done to assess options for unruptured AVMs, asymptomatic AVMs. And the study authors aim to compare any treatment, surgical, microsurgical, interventional, or radiosurgical, to quote unquote medical therapy, which I'm not entirely sure what that means, but a non-procedural approach essentially. So it was a randomized study, and I just want to point out a quote from the introduction that bothered me a little bit, and I hope I'm not to offend anyone. This was sort of part of the rationale for the study, and part of the reason why many North American centers didn't participate. Furthermore, first-time syndromes are often mild, with bleeding often mainly confined to the brain arteriovenous malformation itself, or originating from the venous side of the malformation. That didn't quite match my reality of what I see with AVM hemorrhage. So, what about all the associated aneurysm ruptures, et cetera? So this was sort of part of the rationale for the Aruba study, for what it's worth. Again, this was the design, 39 sites in 9 countries, adults 18 years or older, randomization 1-to-1. 109 were in the conservative arm, 114 the interventional arm. Follow-up was halted at 33.3 months because the endpoints were reached much at a higher rate than expected in the treatment arm. The endpoints were death and symptomatic stroke. Stroke was defined as a clinically symptomatic event, any new neurological deficit, seizure, or new onset headache that is associated with imaging findings of hemorrhage or infarction. Death or stroke occurred in the conservative arm in 11 patients and in the interventional group in 35 patients. So which AVMs were treated in Aruba? 76% were grade 1 and 2. That's why I showed you the Spetzer-Martin grading scale. So close to 80% of these AVMs were AVMs that have low treatment risk. You may or may not want to treat them, but if you do treat them, the risk of surgery is quite low, in the low single digits. 28% were grade 3. Grade 3 are mixed. Some of them are good for treatment, some of them less so. 8%, interestingly, close to 10% were grade 4 and 5, grade 4 AVMs. Why were they treating asymptomatic grade 4 AVMs is not clear to me. This is the breakdown of presentation. And interestingly, in Aruba, 54% were in quote unquote eloquent area. And they define eloquent as sensory motor, language, or visual cortex, hypothalamus, thalamus, internal capsule. So really a lot of deep AVMs. Maybe AVMs people weren't excited to treat anyway. So that's an issue. I'll skip over this just for time. So how were the AVMs treated in Aruba? Shockingly to me, only 5 were treated with microsurgery. 80% were these grade 1 and 2 AVMs that are pretty easy surgically. Only 5 were treated surgically, 30 with embolization, 31 with radiosurgery. Microsurgery plus embolization in 12, embolization plus radiosurgery in 15. Embolization plus radiosurgery, in my mind, is a bit controversial, but I know there are different opinions on that. But so this is an interesting juxtaposition of these type of AVMs and their treatment. I'll skip over this. So one of the issues I have with Aruba is that all the treatments are treated the same: surgery, endo, radio. It's kind of like you're studying hypertension, and you can say, okay, any drug compared to no drug. And it's hard to parcel that out because a lot of what defines success in AVMs is the strategy and how you use these tools. And I think, to be honest, the Aruba was conducted mainly by centers that had a strategy heavily focused on embolization alone, which we know can work for some AVMs, so you have to be careful which AVM you pick, or embolization with radiosurgery, which again can work if you're very judicious about it. So there's a lot under the hood in terms of patient selection. And then one of the issues you have to think about is if there's a stroke. So let's say you have a young lady with an occipital lobe AVM. Is a visual field cut a fair trade-off for cure from an AVM? I don't know the answer to that, but in Aruba, that would likely have been counted as a stroke. So there are some strokes, or if somebody has some hand weakness after a premotor AVM resection that could get better with rehab, is that a fair trade-off? And I'm not saying I know the answer to that, but it's something I don't think we as a community, neurology and neurosurgery, have a full handle on. Are all strokes the same? And I think that, and what is a stroke when you're treating an AVM is something I don't think we have a full handle on. And in terms of follow-up, is 33 months when you see if Dr. Vaz or Dr. Rami or Dr. Binning or Dr. Liebman see an AVM in a 22-year-old, they're not asking, am I going to be okay for 33 months? They're asking, what does this mean for the rest of my life? I'm planning to spend the next 10 to 20 years starting a family. I want to have a career. I'd like to be a grandparent one day. I have a 50-year plan for my life, a 60-year plan. What does this mean for my life? And we don't have a handle on that, quite frankly. Some of the problems, just to summarize with Aruba, are very low occlusion rates in the study. I think those occlusion rates would not be accepted at GNI or Mayo Clinic. Causes of stroke were not entirely clear. Adjudication of skill was not clearly stated, or maybe not a big part of the study. And when is a stroke, quote unquote, an acceptable trade-off to cure an AVM? Is a minor deficit acceptable or not? That's a very individual discussion. And then causes of death were not entirely clear in the study. Anyway, I won't belabor it more. I want to get into some of the more treatments because we have limited time this morning, but these are some of my very biased thoughts on Aruba. So let me talk about a couple myths and some of my thoughts on that. We're taught in medical school and residency that all AVMs are embryological in origin. Yes, most of them are, but there are a number of case reports on post-radiation induced AVMs, moyamoya disease induced AVMs, sickle cell, band heterotopia trauma. So you can see AVMs develop in other scenarios. This is my favorite myth. AVMs are static and don't change over time. Saying that an AVM is static, we tend to think of mountains as a symbol of stability. And mountains, in fact, if you look carefully, are changing all the time. They're in evolution. Same with AVMs, they're not static. And don't be biased when you get an MR report that says AVM is unchanged. What does that mean? Just the size of the AVM? Does it mean, what about the aneurysms in the AVM that are hard to see? So AVMs are almost never static. So this is a 12-year-old male that I saw. I met him later in life, a couple years after, but he initially presented 12 years old. I didn't meet him at that time with this incidental AVM. And I wouldn't fault anybody for missing this. It's a very small premotor AVM, very tiny. See that abnormal vessel there. And he was advised radiosurgery, but got lost to follow-up. And then he presents, so that's it, at age 12. At age 18, 6 years later, he comes back with a tonic-clonic seizure and now has this AVM. This AVM is not static. No one would miss this AVM now. Even first-year medical students could see that. And so AVMs are not static. We're biased by our limit, by how we image and how frequently we image. So as we think about innovating treatment of AVMs, one thing I've thought about in my career is, what does eloquent mean? When we call the frontal lobe non-eloquent, we may be offending Mother Nature, because you could argue that the frontal lobe could be the most eloquent piece of tissue in the universe. So this young gentleman with a premotor AVM, we mapped his motor area that sits right behind the AVM. But the cortical mapping is only part of the story. This is hand function behind the AVM. Again, looking at hand function there. But what about the white matter tracts? When I'm working on an AVM or tumor, what worries me more than the cortex is the white matter. White matter is where all the significant deficits can come from. And so you want to do something more detailed with white matter. That's where I think the more important part of the story of the human brain is. So this is the cortical spinal tract in this AVM. We can look at it in 3 dimensions with spectral imaging. This is very helpful to a surgeon to see where those fibers are and to look at them. So we look at things in 3D. Everybody talks about 3D. Is it in 3D? Well, what about 4D? What about time? Time is an important dimension when you think about AVMs. What is time? And so here, this is a 4D MRI looking at flow in every single pedicle. We've published on using this to better judge our embolization strategies when treating AVMs. And red is higher flow, blue is lower flow. And you can monitor this over time. And we should be looking at this fourth dimension when we think about AVMs. Any AVM, please order time resolved imaging. Don't forget about the T axis when you're thinking about AVMs. And so we developed a couple papers with the physics group here back at Northwestern, Tim Carroll and his colleagues. And what about the fifth dimension? What about the biology? So this is from a colleague of mine at Northwestern who looked at this is from a mouse model where he could tag antibodies and look at image the brain with molecular imaging. And in the future, we should be getting molecular studies of AVMs, looking at MMPs and inflammatory markers to see what is happening biologically. Don't forget, when you look at an AVM MRI, you have no idea about the most important dimension, and that's the biological dimension of an AVM. You have zero clue from an MRI. So what about natural history? You know, when I was a resident, I was taught AVMs have a 2 to 4% annual risk of hemorrhage. That was dogma. That's what we believed. And so we looked at this carefully, and we found that there are a number of factors that can increase risk of hemorrhage: previous hemorrhage, associated aneurysms, development of perforators, infratentorial location, deep venous drainage. Some are more controversial, like AVM size and some other factors, but there are a lot of inputs, risk factors, just much like you think about AFib, or not all AFib is the same, not all ischemic stroke is the same, not all intracranial occlusions are the same. Same with AVMs, very heterogeneous. And when we think about the history of medicine, the era of Hippocrates to the sterile scientific era under Louis Pasteur, we now live in the randomized trial era, the population science era, and we're heading into the precision medicine era, hopefully soon as possible, in my opinion. And our residents and trainees and learners are the ones who are going to lead, champion this next phase where you can individualize healthcare, because randomized studies are all about average treatments for average patients. But none of your patients think of themselves as average, and none of you at GNI think of yourselves as average. So that's an issue. Let's shift gears here and talk about treatment. And when Dr. Binning and I, or Dr. Vez and I, or Dr. Rami and I are thinking about treatment, we're thinking about these three tools: embolization, radiosurgery, and microsurgery. These tools, you have to have a deep understanding of these tools. You cannot treat these tools as separated silos. You have to integrate them, whether in the same individual or same team. There has to be seamless integration of these tools. When do you use one, not the other? When should you not use any of them? And when should you mix and match and combine them thoughtfully? So what is endovascular treatment? I don't like the term embolization too much, because to me, it's a very vague term. It doesn't mean a lot. Embolization can mean many different things. There can be preoperative, quote unquote, embolization. You can be interventionally treating a rupture site of an AVM. You can secure a proximal aneurysm in preparation for other things, or as a standalone treatment. Embolization for cure is a completely different treatment. Embolization before or after radiosurgery is a completely different strategy. Palliative embolization, if somebody has severe meningeal headaches, but you can't cure their AVMs, embolizing the MMA may be an option. Venous stenting can be an option in select patients who have venous stenosis. That's a completely different strategy and treatment and technique. What about embolization before radiosurgery? I think in very select cases, this can be an option, although the literature is divided. It's thought that embolization may reduce efficacy. So if I'm going to embolize with radiosurgery, my personal preference, and I know people vary on this, is to embolize after radiosurgery, but I know there are differing opinions on that. And there are some cases where that may not be true. But there's some data suggesting that you may reduce efficacy of radiosurgery if you embolize before. I think that's to be distinguished from taking a larger AVM where you can truly embolize a compartment and reduce its size for radiosurgery. That may be a different story. What about this idea, and I think this played into the Aruba study, of just serial embolization of grade 4 and 5 lesions. This was very much done in Europe. And the problem with this, without an end goal of complete cure, the problem with this strategy is you recruit new feeders that turn an AVM that was very bad into a monster. And so you may actually worsen the natural history. So this is a paper looking at what happened to these grade 4 and 5 AVMs that were embolized over time. They weren't embolized to cure, they were embolized just partially. And it turns out they had a higher rehemorrhage rate than their conservatively treated counterparts. Obviously, there may be biases in these studies, and you're maybe more likely to treat AVMs you're worried about, et cetera, et cetera. So I don't claim that this data is clean, but we have some anecdotal concern that embolizing without a clear endpoint may not be a good strategy. I think almost always you have to have a clear endpoint for what's your goal with an AVM. And if you're going to start messing with an AVM, complete cure should be your goal in most cases. Now, that's to be distinguished from, I can't treat this AVM or shouldn't treat this AVM, but I'm going to treat the associated aneurysms to reduce risk of rupture over time. That's a very different story. Embolization for cure, a word of caution here. This can be a beautiful technique for select small AVMs. If you start messing with large AVMs and eloquent area AVMs with this, you could actually have a pretty bad outcomes. So this 71-year-old gentleman came in with a sentinel hemorrhage, had a small bleed around his AVM, small superficial AVM, very easy for surgery, but he wasn't a good surgical candidate, had bad pulmonary disease, so we kept him awake. This is the AVM. This is the angiogram, simple compact nidus. This is the billboard case for trying to cure with embolization. This is quite easy to do. Catheterize that big feeder and then injected onyx and casted the AVM. Quite fun to do. And here's a cast. And he went home the next day and he's been cured since. What about venous stenting? Wow, why are we talking about venous stents with AVMs? So this is a case that taught me a lesson. This is a patient who acquired a Chiari during our treatment because we were not smart enough to look at the veins. This young violin player had this occipital lobe AVM, and we're like, no, we're not going to treat this. Leave it alone. It's a big AVM, occipital lobe, asking for trouble to treat this AVM. We're going to leave her with a big deficit. So we said, nice to meet you, and good news, you don't need treatment. But then she kept coming back with worsening symptoms. And over time, she developed a complete homonymous hemianopsia. Wow, that's no hemorrhage, just a complete homonymous hemianopsia. And the AVM was basically, it seemed like it was eating her up her occipital lobe. Her occipital lobe was undergoing atrophy. I'm like, what is happening here? So we said, we've got to treat this. She's now hemianopic. And so we started to stage embolize it. First embolization went great. Second embolization, she wasn't waking up. CAT scan negative, no hemorrhage. EEG, no seizures. Why is this patient not waking up? And we sat down, looked at the angiogram, and I said, and I had a duh moment. Her IJ was chronically occluded on one side and highly stenotic on the other. She had dramatic venous hypertension. We were too naive to see that, and she had developed a Chiari. She was undergoing downward herniation from severe venous hypertension. And what we did is we took her to the angio suite and stented the stenotic sigmoid sinus. There's the, sorry, let me back up. And we then published on resolution of her Chiari. So we, as soon as we opened the vein, she woke up and the Chiari reduced. Then we went on to treat her AVM successfully. So to pay attention to the venous side, very important lesson I learned from this case. Radiosurgery is a beautiful treatment for smaller AVMs in inaccessible locations. Brainstem AVMs, in my opinion, small AVMs are beautifully treated with this technique, thalamic deep AVMs, because those AVMs not only rupture at a higher rate, but when they do rupture, they're often very morbid. And if I had a brainstem small AVM that was a good target for radiosurgery, I'm going to push people out of the line. I want that treatment because it shouldn't, in my opinion, most of those should not be embolized. Most of them certainly should not be treated surgically, but they are great candidates for radiosurgery. They tend to melt away, very good outcomes in most patients. There can be complications, of course. I'm not claiming it's a free treatment, but I think compared to what it can do to a patient, I think it's a reasonable option, especially in a young patient. And also there's the issue of, for larger inoperable AVMs, you can do staged radiosurgery. We've had great success with many AVMs. It's not for all AVMs. It's not for these really giant AVMs necessarily, but certainly for larger volume AVMs, staged radiosurgery can be an excellent option. This 50-year-old female, for example, she's a high school, single parent high school principal in Chicago. And I really wanted to resect this AVM. It looked like it was under the bone, ready to come out. She wanted no risk. She wanted no time off work. She was a workaholic, did a great job running her school. She wanted a treatment where she could be gone, leave for the afternoon, come back and work the next day. That was her insistence. I said, okay, well, the only way I know how to treat that without surgery, I didn't want to embolize this to cure. I think that's asking for trouble, is to divide it into two, and it's too big for single fraction radiosurgery. So we divided into two AVMs. Here's the angiogram. And treated it over 3 months apart, 2 sessions. The total volume of the AVM was 16 cubic centimeters. So we divided into 2 8 cubic centimeter volumes, essentially, and treated each. And she went on to complete occlusion 5 years later. This is before on the left, after on the right. I saw her for a 5-year follow-up recently. And she has I think Rudy and I did this follow-up angiogram, and she has a clean angiogram at 5 years, doing great, still running her school and doing very well. So it can be a great treatment. Where I have had trouble is in the massive AVMs. Then you start to run into radiation, but proton beam may be an option for some of those. And won't talk a lot about that today, but that is an evolving option. What about microsurgery? Let's go back to that 12-year-old that I met again at 18 with that premotor AVM. Here's the premotor AVM. And so can you treat this with radiation? Yes, he's 18, but you'd like to give this gentleman a quick cure. He's now having seizures, so there may be some advantage to microsurgery. But if you're going to do it microsurgically, you'd like to dry this up a little bit. So we embolized it, and then at surgery, you want to very carefully monitor the motor cortex and map the motor cortex. We like functional imaging, but we like to confirm that with phase reversal and direct cortical stimulation when possible, and white matter stimulation. So here's our grid and it turns out the motor cortex is behind us. So we're opening up the subarachnoid space around this AVM. And when you look at this AVM on the surface, when you're new to AVMs, you don't know where to start, but the best place to start is to open up the subarachnoid space very carefully, gently, methodically, and very carefully unravel that spaghetti bowl. And what you wind up in the end is an ice cream on a cone. So the AVM nidus is the ice cream. It's typically in a tangle, and when you untangle it, here we're just, the AVM jumped a sulcus, so we're getting into this gyrus just to the side of the AVM. We're working circumferentially down, and I'll go a little faster here. Here we're creating some channels circumferentially. The draining vein is just anterior to us, and sequentially devascularizing the nidus, working sequentially and patiently and carefully and methodically. Eventually we get to the depth where the bipolar doesn't work very well for the deep feeder, so you have to use AVM clips. You have to bring up into your suction very gently and apply AVM clips very methodically. And here we're just basically devascularizing in the depth. The nidus is almost completely detached. And here we're using an AVM clip for a deep feeder. These can be a little pesky. They don't respond to bipolar, but they do. You can get them closed with AVM clips. You just have to work very methodically, get the feeder into your suction, and they do fine. And in the end, we have the ice cream. Here's the nidus completely laid out, and then we divide the draining vein, and the patient's cured. He woke up with a little bit of hand fine motor weakness, but that resolved completely in a couple of weeks. He's completely intact with a cured AVM. I think a good outcome in this young premotor area AVM. This other patient is a 36-year-old female with new onset seizure. She was a one-hit wonder singer, and then turned to opera. So opera was her life, and she was terrified that she would have a seizure on stage from an AVM, this AVM that was diagnosed, and she was terrified that she would rupture the AVM with the deep, the kind of pressure she had to generate for opera singing. So the AVM was quite small, but there was a lot of hemosiderin stain in this eloquent left posterior temporal lobe. So how do you deal with that? First, do you treat this AVM? She's a young patient having a seizure, but her seizures are not just from the AVM, they're from the hemosiderin. How do you take out that hemosiderin? And as somebody who's a singer, she wants her singing abilities. The AVM is quite small and trivial, but there's a lot of hemosiderin around it. So we decided to keep this patient awake and map her speech area. This is the AVM. There's one en passage vessel. Not a very difficult AVM from a surgical perspective. So we mapped her.
Go ahead and start whenever you want.
She's awake now. We're testing her neuropsychologically. We have neurology and neuropsychology in the OR. And we wound up with a map. And you can see the area of the AVM is very quiet. We mapped all sorts of speech areas here. And there's the AVM with the arrow. So we thought we could work with impunity around that. And here we're basically skeletonizing the AVM. We're going to preserve the en passage vessel. There's an en passage vessel there. We're going to basically trim coagulate the vessels going to the AVM, but preserve the vessel that continues beyond the AVM to avoid a stroke. And here you see we've preserved the en passage vessel. The AVM now is almost completely detached. The draining vein is turning dark, and a couple more feeders to detach. Then we're going to clean that hemodesiderin stained brain while we're monitoring her speech. And we don't like to do awake surgery for most AVMs, but this was a small one where speech testing was important. So we thought this was a great candidate. So here now we've completely unraveled the ice cream. There's the ice cream on the cone. See, you've got an ice cream on a cone at the end. Now we detach the draining vein, which is going right into labet. Preserve labet, but detach the draining vein into labet. Now the ice cream is laid out on the, there's the ice cream on the cone. But you had to unravel that. You have to work for a number of hours to unravel that. And there it is, unraveled and cured. And she went back. I attended a concert for her a couple months later. I was very nervous sitting in the front that she was going to blow something, but she did fine and went on to continue her career in opera. So this is some of my favorite scenarios in neurosurgery. This is what makes you really excited to be a neurosurgeon. I call these the night of the living dead cases. And this is a 55-year-old, so there's a typo there, patient with hypertension, AFib, collapsed at work, GCS3 in the ER with this posterior fossa hemorrhage. You don't call hospice here. You don't call, this is something where if you're going to save this young patient, you've got to get him to the OR. He has early hydrocephalus, and this is vermian clot. Almost every vermian AVM I've seen present comes in a coma near death. And almost every one of them we've been able to save if you work quickly, if they haven't been down at home for forever. If you get them quickly to your OR, you can save these folks. But what you have to do is take them right to the OR, put an EVD in and do a craniectomy. Maybe some of the clot, buy some room, get them back to the ICU, and actually get them to the interventional suite to figure out what hemorrhaged. In this case, what hemorrhaged wasn't the AVM, but this flow-related aneurysm that we quickly coiled. This was, I think, at 2 in the morning after we did the craniectomy. Very easy to do in the hands of folks like Dr. Liebman and Dr. Binney. Here's the coil mass. Got him back to the ICU, and he slowly improved. 3 months later, we resected his AVM, and he went back to work. This guy came in the ER. He looked dead. He had no cranial nerve exam. He looked dead in the ER, but this is the Lazarus procedure, I call it. Vermian AVM hemorrhage. I love these cases because you can bring them back, but you have to act fast. You can't dilly-dally. You can't, be kind of wasting time. You've got to get them quickly to the OR. You have to treat this like an embolectomy case. How about this case? This was a patient related to a hospital administrator where 32-year-old female had this motor area, big AVM. We did not want to treat this. I didn't want to treat this, but she kept coming in every year with progressive weakness. Finally, after knowing her 5 years, she came in a wheelchair. She was losing function on the opposite side of her body. Never had a true hemorrhage. Just this, again, some of these bigger AVMs, they tend to eat away at the brain. And look at this AVM is doing part of the surgery for us. So we said, gosh, we don't have any option here. She had a lot of deep feeders. So we started to embolize this. First embolization went well with a plan to do surgery after 3 or 4 embolizations. Second embolization, she did not wake up and had this scan. We all know the mortality from this is 90%. I'm going to try to wrap up here. And so we took her back, embolized the rupture site, gave her TPA in the ventricle. Here we are, is day 1, day 3, day 4, day 5. This is with TPA day 6, day 7. And wound up, we went on to treat the AVM, didn't even need a shunt. Could not have done that without collaborative care, like you have a GNI between neurosurgery, neurology, and critical care. Very critical, the teamwork that was needed to save that patient. She went on to treat the AVM. She had her baseline hemiparesis, but wound up being cured of that AVM. This is I'll end with this case, a 41-year-old female who presented to us with progressive, severe hemiparesis, severe alcohol abuse, and severe medically refractory seizures, and has this CAT scan, severe, I don't know if we call this edema, you'll see what I mean when you see the MRI. This MRI showing this AVM with incredible T2 signal changes in the brain. This made me really nervous. Seems like an unstable AVM, very symptomatic patient. ugly nidus, superficial drainage and deep drainage. And I believe Dr. Rami was with us when we treated this AVM. And here we mapped the motor area in front of the AVM. There's a cortical spinal tract in white there, the tracks that you see. But I was worried about how edematous brain looked. And if I took her to surgery, we were worried that we would have major problems at surgery with just what would happen to that brain tissue around the AVM. So I decided to stage embolize this. And I think Errol's going to like this case. So we embolize this, Dr. Rami and I, over 3 sessions. Devascularize it gently over the course of about, I think, 6 to 8 weeks. And fundamentally, we didn't aim for cure, just to kind of reduce the flow. And what I love about this case, after the 3rd embolization, we got another MRI. And look at the MRI before embolization and after embolization. We had completely normalized that tissue around the AVM. Probably my best example in my career of the positive impact of embolization before surgery. Then we went on to take her to surgery. So here, the draining vein, the big draining vein, was up against the dura. In fact, and I was worried that just placing a burr hole, we could rupture the AVM. So we actually mapped out, this is using virtual reality, we mapped out the draining vein vis-a-vis. So I actually planned my burr holes to be around the draining vein. So you don't want to do this burr hole, for example, on the left, you do the one on the right, you go in front and behind. And here is at surgery, we're superimposing this virtual reality onto the patient with augmented reality. This is us just rehearsing the surgery before with flying through the AVM and looking around to see what are we going to do, how are we going to find the feeders, and rehearse that way before surgery. And again, placing the burr holes in this case was, to me, the most dangerous part of the procedure. And at surgery, in fact, the draining vein had eroded the dura. So had we put the burr hole over it, we could have ruptured it. So we very carefully had to manage that with multiple burr holes. And here it is at surgery. We've now exposed the AVM. We're going to be using several forms of augmented reality here. There's the ICG superimposed on the field. And we're opening the subarachnoid space, small or big AVM, same principles. We're going to work circumferentially. This AVM had a draining vein towards the sylvian system and another one towards the sagittal sinus. So very circumferentially, we're going to devascularize this AVM and continue to work circumferentially. And then at some point, to be able to get under the AVM, we're going to detach the sylvian side of the drainage once we've really got it down to a trickle in terms of flow. Put a temporary clip on the sylvian side, and that was well tolerated. So then we detached that side. This allowed us to roll the AVM up out of the cavity towards the sagittal sinus. Here we're using AVM clips in the depth. You're going to see us here in a minute detach that sylvian vein because it was kind of tethering us to the cavity. Yeah, there we are dividing the sylvian side. And at this point, we're so devascularized that it was well tolerated. Dividing an ACA feeder there. And now all we're left with is now the ice cream. This is a triple cone ice cream, 3 scoops on this sagittal sinus draining vein. Now we're placing a clip on the draining vein and dividing the vein. This patient went on to have a great outcome. We got her off alcohol with our Mayo team. Her seizures are controlled now, and she's her hemiparesis, she's down to like 4+ out of 5 weakness, where she presented 2 out of 5. So doing much better than before surgery. Post-op angiogram shows complete cure. I'm going to skip this case just because we're low on time and just kind of wrap up here. Just a little bit about the future, just a couple slides on the future. I think the future, I'm really excited about virtual and augmented reality. I think we're just at the dawn of a new era of how we think about surgery, both robotically, engaging AI, robotics, virtual and augmented reality. I think the ultimate goal is for Dr. Vez and I to have our beach houses in the tropics, and we can do robotic surgery and help Dr. Rami remotely from our remote mountain or beachfront cabin and do telehealth and remote surgery. So 3D printing and holograms is something we're now bringing a hologram to every patient in clinic. 3D prints we do selectively, but I love virtual because it's cost effective. It's easier and easier to do every year. And we now bring these holograms in the clinic to help educate our students, educate ourselves, rehearse, and engage patients better. Then we bring these to tumor boards, and we then blend this data, this avatar data, with the patient to create a virtual and augmented reality environment in the OR. So our ORs are becoming a metaverse. And so here's Dr. Vez and I operating remotely, robotically. And then I'm excited about blending technologies in the OR, whether it's robotics, fluorescence, augmented virtual reality, et cetera, et cetera. What about telehealth? What about telestroke? I know this is something that GNI has mastered. We're really excited. And here in Phoenix, we're putting our neurologists into the ambulances. We find that this is more cost effective than a CT on an ambulance to get a neurologist into the ambulance with telehealth. We think this is actually the future, and not putting a CT on an ambulance. It's more scalable, I think. Again, this is just in a case where we used augmented reality in this pilot to treat this AVM. Again, we're really excited about where that's going and where we can take it. And here, just to show you really quick how we used the augmented reality to superimpose it on the AVM to help us stay oriented in ways that required before 20, 30 years of experience to stay oriented. Now, even our medical students can stay oriented by using augmented and virtual reality. So on that note, I'm excited. Thank you for the honor of being invited to GNI to speak. I greatly appreciate this very prestigious invitation, especially since we have these deep friendships between GNI and Mayo Clinic and myself personally. Very excited about the future. Let's invent the future together. To all our students in the audience, I hope you get excited about AVMs and join us in a quest to get safer and better cures for every patient. Invite you, it's a bit late now to sign up, but in case any of you are looking for a getaway from the East Coast, join us December 14th through 17th in Sedona for our annual Neuroscience Symposium. Perhaps we can have more of you there for the next one too in early 2024. So on that note, I'll end, and thank you again to Dr. Vez and Dr. Rami and the entire team there at GNI for inviting me to speak this morning.
Bernard, great. Thank you. That was fantastic as always. Really one of the best AVM lectures always is Dr. Bendock, because he can put everything in context. And, our audience is a very varied group, and from the most expert, person that's been treating these to someone who has never even heard of an AVM. You did a great job. So there's a lot of questions, so I want to give some time here to them. The first question is, how has the Aruba trial affected your treatment logarithm and what you tell patients based on that? What's your, talk?
Well, my answer to most problems is to educate myself and to educate the patient. And Aruba, I think I'm glad Aruba was done because it taught us a lot of things. In fact, it reinforced my belief that what matters the most with an AVM is strategy, and also distinguishing and really doing a deep dive on the specifics of an individual AVM. AVMs are, all diseases we treat are heterogeneous, but AVMs are particularly heterogeneous, and not all AVMs are the same. And so I think you really have to be, you have to think about a lot of things with AVMs, and you have to educate the patient and their family to the point where they can become true partners in that planning. Now, there have been a number of papers, I'm sure you're familiar with this, Errol, that have come out recently showing worsening hemorrhage rates in North America from AVMs. Yep. Because of the conservatism that has arisen out of Aruba. Some of the conservatism I'm okay with. I don't want to treat a grade 4 or 5 AVM if it's asymptomatic. I'll follow it, I'll study it, I'll educate the patient about it. But on the other hand, I think we need to look past the surface on Aruba and hopefully, most importantly, we need to all come together and plan the next set of studies.
Yeah.
How do we integrate artificial intelligence into? I don't want a study to tell me how the patient's going to be in 3 years. I want artificial intelligence to tell me, what does this AVM mean to the patient in 40 years?
Right. No, absolutely.
Or 30 years, and so that's. And I think that's what a parent is asking when they bring their 17-year-old daughter to your clinic, and we have to be honest about what we know, lay out Aruba, but honest about what we don't know, which is much greater than what we know. So that's how I look at it.
The data is actually interesting, and the very first patient that was enrolled in Aruba at Columbia was a gentleman, 55-year-old professor in Princeton, who was randomized to no surgery, medical treatment, and to your point, whatever that means. Within, I think it was 18 months, he ruptured, and we treated him up in New Jersey. So that's an easy discussion for us. We're like, yeah, the first person that was randomized to that to no surgery ended up with surgery. But yeah, more to be told. So someone asked, they want to know more about your technique with brain mapping and how you integrate with radiology and in the OR.
So we formed this brain mapping team that consists of 2 IOM neurologists, intraoperative, and 1 psychologist who has expertise in functional MRI. She's unique because She has background in radiology, but she also is a trained neuropsychologist.
Hmm.
And they come with us to the OR. And they also have a clinic. So I'll have them, they meet our patients in clinic, they get to know them, they get to know their goals, their function, their life. I had a psychiatrist once where they sat with them during the left temporal lobe surgery and were doing, testing their ability to integrate with to interview a patient. So it's very individualized. It's probably one of the things I'm most proud of that we've done here. And I tell a patient, and it's actually just with my business hat on, it's a great market differentiator to say, hey, we're going to take the time to map your brain and learn what we can, but it's not just pre-op, it's intra-op and post-op. So if you have somebody with a deficit, let's figure out what happened intra-op, what does a tractography look like post-op.
Yeah.
So it's this continuous feedback loop where we're learning more and more about these tracks. And because a tractography, we're at the dawn of understanding what it all means, and how do you integrate that into this whole idea that there's eloquent and non-eloquent brain is very simplistic and naive. The whole brain is eloquent, and so how do you navigate that in a way that is individualized? And we're really, and would love to share, if you'd like to come, happy to connect you with our team if you'd like to visit with them. And so delighted with your interest. Yeah.
Well, that's why you guys are crushing the barrel. So I'm going to combine two questions because they're similar and I think they're pretty simple answers. What's your follow-up for pediatric population once you've developed angiographic cure, as far as follow-up? And then same thing with radiosurgery. Once you are done with somebody, when do you consider it a cure? What's your follow-up?
So the insurance companies and the cost control folks probably won't like me for what I'm about to say. I like to follow these people for life. I don't always use contrast to kind of minimize the long-term gadolinium load, but I don't think we know what the things look like. So I just do a phone call follow-up, MRI in a year and a phone call. So I believe in long-term. So specifically pediatric AVMs after even complete surgical cure can recur. We've published on this. Others have published on this. And so those patients deserve a 5-year follow-up angiogram in addition just MRI. And for radiosurgery follow-up, for Dr. Benning's question, I also like to get a 5-year follow-up angiogram, because when you look at the Pittsburgh data, even for tiny AVMs, it gets up to 90% cure, but that's after 5 years, not after 1 year. And so I usually get annual MRI and time-resolved MRA, and then I seal that with a 5-year angiogram and then follow them with MR maybe every couple of years for life thereafter. Well, that's my approach, and it's sorry.
Well, no, I was going to say that's the right approach, because actually Zach Hakma in the post, you can see, he had a patient that was quote unquote cured post radiosurgery with angiographic confirmation of cure, and then they had a bleed in the exact same area 5 years later. So
I'm not surprised. We need to follow these patients carefully. I'll tell you another thing is that that principle I showed you, I left one thing out of her story. Her AVM looked cured angiographically, but Dr. Rami and I picked up a small dural connection to the AVM that was still alive. Could that have been significant? So I think it's very important that not only do we get follow-up imaging, but we get very thorough follow-up angiography. I think that we're fooling ourselves if we just get, a common carotid angiogram and say, oh yeah, it looks cured, there's no draining vein. I think we have to look closely at these patients. Sometimes we're biased by what we see or what we don't see based on our pre-test biases. Oh yeah, it looks cured on MRI, it's probably cured, and we do just sort of a 2 frame a second angiogram. And
right.
But so I think these patients merit and deserve our close attention, and I think there's a lot that we've learned a lot in the last 20 years, 30 years, but we also have much more to learn.
Yeah, no, well said. And so we have a couple minutes here, and I want to get everybody's some of the salient questions here. So a couple more just yes, no's. Your thoughts on WADA? Do you do WADA testing before treatment?
WADA testing. I'm a big fan of WADA testing for left temporal lobe assessment. So yes, we'll use it for there, but the only caveat is in AVMs is you have to know where that drug is going.
Yeah.
Because of the shunting. So as long as you factor that in, there is a role for WADA testing. I'm a big believer, the more we know about a patient before surgery, the better. but you just have to know what your test is telling you, what it may not be telling you. And so WADA has always been thought to be a little problematic in AVMs because of that shunting and the flow, but for select AVMs, I think it could be valuable.
Okay, great. And the last question, which is a great one from your protege. Fantastic talk as usual. What advice do you have for young vascular neurosurgeons when they're faced with these difficult AVMs, specifically when there's a dilution of volume in the post-Aruba world for surgical cases? And your thoughts on the controversy of the size of the AVM and risk of rupture?
Yeah, I probably don't have enough time this morning to answer that in full, but Dr. Rami, what I'll tell you is keep doing what you're doing, keep studying AVMs, keep talking about AVMs, keep advocating for patients with AVMs, and start your own study. Let's start a GNI Mayo Clinic study around these controversial, but let's be careful how we do the study. And I think grow our knowledge as a community. So I would say, don't be discouraged. I think learn what you can from Aruba, and then let's plan the next return to paradise study, so to speak. And so that's my short answer, but let's continue that dialogue over time. Maybe plan a Mayo GNI study.
Done. Well, listen, Bernard, thank you so much. This was an
My
incredible
pleasure.
Grand Rounds as expected. Really look forward to seeing you in person and getting you out in person for a real in-person Grand Rounds to meet with everyone.
Would be my pleasure. Thank you, everyone, and good to see all of you. Thank you, Errol.
Thanks, everyone.